Thank you, everyone. Welcome to this session. I'm Rebecca Bentley. I'm a social epidemiologist based at the Melbourne School of Population and Global Health. Before I begin, I would like to acknowledge the Wurundjeri people who are the traditional custodians of the land on which I'm on. I'd also like to pay respects to the elders, both past and present, of the Kulin Nation and extend that respect to other Indigenous Australians present. So thank you for attending this second seminar of the Hallmark series. This is the Healthy Housing Seminar. The Hallmark project seeks to bring together a range of disciplines across the university to look at the issue of housing affordability. And the seminar series is designed to showcase the projects that we funded during the year that sought to do this. And I'm the Hallmark Health Lens leader, so I've been following the development of this project quite closely. And today we're going to hear about examining the relationship between indoor temperature and health. So there's mounting evidence that exposure to unhealthy indoor temperature has a negative effect on health. An inability to avoid indoor cold in housing leads to hypertension and is a risk factor for premature mortality and cardiovascular disease. So the potential to use housing to reduce our overall burden of disease in Australia has not been fully explored, and there's a number of reasons for this. And one of them is that until this point in time, we haven't really had the right methods to model it out and to do this. This project was funded as a pilot to redress this, so to think about the way that we could start to think about the contribution of housing to Australia's overall health burden. And we chose to look at cold housing in the first instance because it's got a clear pathway through to cardiovascular disease, and there was an ongoing and interesting body of work in this space. So this project was funded to pilot this new method. So it's a bit of an exploratory piece of work. Ankur Singh is the researcher who's led the project. He's worked with a team of epidemiologists, architectural scientists, biostatisticians, health economists and others to model out the benefits, and he's going to present that today. But we've got a number of other presenters as well to round the series out, or the seminar out. We're lucky enough to have Lucy Telford-Barnard from the University of Otago, who's been at the forefront of work to improve housing conditions in New Zealand. They've made great gains in New Zealand in establishing a healthy housing agenda and a push for minimum standards, and Lucy's been central to some of that work, and we'll talk about that today. We're lucky enough to have Luai from engineering, who's going to provide an engineer's perspective on indoor air quality. So offering another perspective on the issue of how we can understand what's happening inside people's houses and how that's, eventually going to impact on their health. And then we're lucky enough to have Lyrian Daniel, who is a partner on Ankur's project and has a long-standing research program looking at cold housing in Australia. So Lyrian's been working really hard to develop methods and conceptual frameworks for thinking about cold housing and who's at risk of cold housing in Australia, and has published some really interesting papers on that. So without further ado, I will introduce our first speaker, who's Ankur Singh. So Ankur is a research fellow in social epidemiology and lecturer in epidemiology at the Melbourne School of Population and Global Health. Ankur's developed his capacity in the discipline of social epidemiology through his research in the housing and health space over the last few years, and he has a strong focus on health inequalities. He's also currently the chair of the Global Working Group on Social Determinants of Health in the International Union for Health Promotion and Education. So I'm going to hand over to you, Ankur, and I look forward to your presentation.
Thank you, Rebecca. Just going to share my screen. Did it work?
Yes, that's worked well.
Thank you. So thank you, everyone, for attending this seminar. I'm going to present on the first presentation, but also on the project that was funded through this Hallmark initiative, which is called Simulating Population Health Impact of Eliminating Indoor Cold in Australia. And as Rebecca has mentioned, this included a great team of people from across three universities, University of Melbourne, University of Adelaide, and University of Otago. So to begin with, I'd like to stress that the relationship between housing and health is something not of a new concern. It's been there for a long time, and pretty much, if you look at the public health literature, the first and foremost sort of work which establishes the impact of residential environment on health fits in the idea of housing and health. And most of the outcomes, those were explored at that stage, were around infectious diseases, asthma, mesothelioma, and lung cancer. But now more so, in recent times, we've seen around cardiovascular diseases and mental health as well. But to bring it all together, I think in this report by World Health Organization on housing and health guidelines, it kind of looked at multiple exposures and looked at multiple outcomes, health outcomes, to summarize the evidence and to actually form guidelines to be followed for looking at, for informing housing interventions. So as we can see here, there were several exposures and outcomes, but for this particular pilot, we chose indoor cold and cardiovascular diseases, for the reason being that there's mounting evidence on the relationship between indoor cold and health. And also, as we know, cardiovascular diseases is probably the biggest cause of mortality in the Australian context. So why do we need to do a simulation modeling? Well, it's quite interesting because the job of a policymaker is not straightforward. So, for instance, a policymaker who needs to make a decision on an intervention per se would be looking at a range of interventions, and there are finite time and resources to actually make a decision. But they need to be compared on something, and just knowing that housing affects health is not sufficient for that. We need something more than that. And that's where the simulation modeling in epidemiological sense has become quite useful now, where people are able to look at multiple interventions at the same time and then compare their effective, population health gains or return of investment, if you like, for all of these. And why is it important? Again, this is another example. This is not where I did my sat and applied my model. This is actually a flight simulator to just give you an idea that you need something futuristic. You want to see, what your best return of investment would look like on an intervention in future. And therefore, I think the simulation modeling becomes quite important tool to give policymakers a sort of an idea or, look into the future, how much, investing on a potential intervention is going to give them in return. So for this model, what we did, this is the 2016 living population of Australia, where based on the Australian housing conditions data set, we knew 6% of the people were sort of unable to warm their homes. And with the magic wand in the modeling, what we did, we said we eliminated that. So nobody under our intervention would be living in cold housing per se. How does it help? It really helps because it tells you if you were to direct all the interventions to this exposure, how much health gains you're likely to achieve. So that's where our intervention comes from. And we use the best available data. And like for modeling, data sources are really important, but also you need diverse sources of data on different characteristics. So just as an example, you need data on demographics, cardiovascular disease epidemiology, but also on indoor cold. And now, in the interest of time and without further ado, I'd actually show you the preliminary results that we've got from our modeling work. So this is basically listing from lowest health gain to the highest right now in this league table for all the cardiovascular interventions and the Halley's per thousand. What Halley's mean, these are the health adjusted life years per thousand people. Halley's, as I said, they are a summary measure of population health that again allow comparing multiple interventions. They provide a reference really. So you can see here, dietary advice for adults gives you about 0.017. And On the other hand, something like a mandatory tick program to reduce salt in bread, margarine, and breakfast cereal gives you about 3.76. And across, there were about 93 interventions at the University of Otago League Table for Cardiovascular Diseases. Our intervention per se was found to be ranked 62 of 93. So that may not look a lot to you, but let me tell you, of those 93 interventions, most of them were very clinically focused. So for example, polypills or statin or aspirin. But if you look at the public health interventions in this list, you see that the removal of exposure to indoor cold is actually comparable to a large number of public health individualistic interventions here. So dietary advice for adults, lifestyle program for adults. The return on investment is much larger compared to these in relative terms. So it's really important to then think that among public health measures, you will actually get biggest bang for your buck if you were going to invest on removing exposure to indoor cold. So in short, I think what this exercise has done is it's sort of built the first simulation modeling of population health impact of housing interventions. This is just a prototype, and a lot of those interventions can now be modeled using the same modeling. I think one of the key and interesting findings from our results, our preliminary results, is that the action on social determinants of health, or in terms of housing, is actually going to give you much more return than on some individualistic interventions, for example, dietary advices and things like that. And those are expensive. And we need to understand that we're just modeling right now through cardiovascular diseases. The core benefits of acting on indoor cold are likely to be much higher. So for example, people's mental health will be improved. They'll be living comfortably. On the other hand, a polypill would only target cardiovascular disease. We accounted for uncertainty in, generous uncertainty in temperature measurement and the relative risk between temperature and blood pressure. But I think this is where a lot of effort needs to go into future to enhance the model as the better data becomes available. And I think something which is already taken up is the evidence on population subgroups is unavailable at this stage. I assume this effect would be larger within some certain subpopulations. We accounted for age variations in the experience of cold for this modeling stuff. But I guess that's the future, if you like, of this project. So some acknowledgements here. I think I have great luxury of working with really good collaborators. Also the Affordable Housing Initiative, because without the funding, this was not possible. And certainly to Kay Traynor and Holly Jones, who made this seminar possible. So with that, I conclude my presentation. Thank you.
Great. Thank you, Encore. That was right on time. Excellent timing. Very interesting. We're going to hold questions off until the end, so we have a significant amount of time at the end. If you've got any burning questions for Encore, write them down now or put them in the chat, but there'll also be the opportunity at the end to ask them. So thank you, Encore. So our next speaker today is Lucy Telfer-Barnett, who's an epidemiologist at the University of Otago in Wellington. Her research is centred on housing quality and extends to respiratory disease, the effects of cold weather on house, and the use of administrative data in environmental health. So very pertinent to what we're talking about today. So she's been involved in the rental warrant of fitness study in New Zealand. She's now working on the demography of eviction in New Zealand and gaps in New Zealand compliance with the WHO Healthy Housing Guidelines. So again, very relevant. So thank you, Lucy.
Kia ora koutou. Right, let's try this screen sharing thing. Okay, we're good to go. Right, I thought I'd just start off with a quick introduction to the research group that I'm in, which is He Kāinga o Ranga, the Housing and Health Research Program. We're a multidisciplinary team. We've been looking at the effects of housing on health for probably around 20 years now, and particularly looking for policy change as a result of the things that we find make a difference. So one of those real successes has been the recent introduction in New Zealand of the Healthy Home Standards, which bring in new regulations for rental housing that require landlords to ensure that the properties are insulated, that they have fixed heating, that there's ventilation, that there aren't any drafts, and that drainage and moisture ingress are managed. And if I've got time at the end, I'll just touch on what's not included there. So if I start with insulation, the new requirement is that all rental properties have accessible, with accessible ceiling or underfloor space, need to have insulation to the required climate zone R value. And the background to that insulation requirement is really the research that we had done showing that insulation made a difference to health outcomes. And not only that it changed health outcomes, but also that there was a cost, that there was a benefit to the cost of doing that. So the total benefits were about 1.5 to 2 times the magnitude of the cost of retrofitting insulation. The result of that was a subsidy scheme for installing insulation in homes, which meant that people could get up to 1/3 of the cost of insulation installed, which we also evaluated and found that it did make a difference to hospitalisation costs and reduce mortality in vulnerable individuals. And the benefit to cost ratio there was about 3.8 to 1, which was mostly from the health benefits. And because of that, the government could make a case for insulation. The next requirement is heating. There now needs to be a fixed heater in the main living area, which needs to be big enough to heat the living area to 18 degrees Celsius on the average coldest night in winter. It can't be an unflued gas heater or an open fire. And if it needs to be bigger than 2.4 kilowatts to reach 18 degrees, it has to be energy efficient. And that was really based on work that we'd done on housing and heating and health, and also on the World Health WHO Housing and Health Guidelines, which Anko mentioned earlier, that had not yet come out, but we knew that they contained this recommendation that indoor temperatures not fall lower than 18 degrees. So we could tell the Ministry of Business, Innovation and Employment that 18 degrees was going to be that requirement, and that should be what they were aiming for in the new standard. There's also a requirement now for ventilation. There will be the requirement to have openable windows in the living room, dining room, kitchen and bedrooms, and particularly extractor fans in kitchens and bathrooms. And that was based on existing knowledge around the necessity for indoor air quality, but also on some work that Phoebe Tapteklis had done looking at the effect of those ventilation fans on reducing mould in the indoor environment. Draft stopping was fairly straightforward. The hardest part there was working out how to word it. So we have this wording of unreasonable gaps, because you can have like a tiny gap but lots of them that let a lot of air through, or you can have large gaps but fewer of them and they also let a lot of air through. So that one will be interesting to see how that plays out. For drainage and moisture ingress, there's now a requirement that rental properties have efficient drainage to remove stormwater, but also there's this new requirement for a ground moisture barrier, so a piece of plastic over the ground underneath a house, because New Zealand, unlike Australia, is not very dry, and so we get a lot of moisture coming up from the ground into the house and causing damp and mould. And again, that was the evidence for that really came from Phoebe Tapteklis's work, because it wasn't measured elsewhere. So those are the new requirements really. And what is not covered there is, if we go back to the rental warrant of fitness that Rebecca mentioned, we had asked for many of these things in our 29-point checklist, and most of the 29 points are now covered off by one kind of legislation or regulation. And the things that are left are really mostly in the area of accident hazards. And that's not so much an indoor environment question, but it is a space where the housing environment does make a difference to health. And as well as injury hazards, we still have other things that are not addressed. So crowding is not covered by the new regulations. Energy hardship is an ongoing challenge. You can put in a heater, but that doesn't necessarily mean that the tenants can afford to run it. Behaviour changes, so the running of the heaters and also the turning on the extractor fans and making sure windows are open and so on are things that rely on tenant behaviour. And then we have the issue of how those new regulations are enforced. At the moment, it's up to the tenants to enforce them through the tenancy tribunal, rather than there being an existing standard that the landlord has to meet before the property is rented. And also, there's no requirement for owner-occupied homes to meet the housing standards. We are expecting an update to the building code sometime in the next few years, but in the meantime, there's nothing there. And then finally, we have this issue of indoor heat, which has not been a major problem for New Zealand up till now, but we expect that to become more of an issue in the future with climate disruption. So that's kind of the state of things in New Zealand now. And that's the end of my 7 minutes. So that was quite neatly done.
Well done. Thank you, Lucy. I'm sure there'll be lots of questions about that in the chat. That was really interesting. Thank you. And it's amazing to see how much work has been done in this space in New Zealand. And I guess it's quite a good model for us thinking about a healthy housing agenda here in Australia. Our next speaker is Lou Ai, who's a professor in energy engineering in the Department of Infrastructure Engineering here at University of Melbourne. Lou has established an internationally recognised research cluster on renewable energy and energy efficiency since 2008. His research includes heating, ventilation, air conditioning, refrigeration systems, waste to resources, complex system modelling. And today he's going to talk about indoor air quality in houses. I'll hand over to you, Lou.
Hi, I am Lou. I'm happy to present you indoor air quality and health. First of all, I would like to thank Holly, Kate, and Ellen for organizing this event. And I also like to thank you for participating. Without you, this event will not happen. Why indoor air quality? We spend a lot of time indoor, as you know, and in our daily life, we consume about 1 kilogram of food, 2 kilos of water, and 20 kilos of air we breathe. So this is a lot of air that we breathe. We're always careful about the food that we eat and the water that we drink. So sometimes we are not aware of what is going on with our air quality. As you can see from this diagram, you will see indoor air environment is affected by several things. For example, HVAC system, occupant, building fit outs, outdoor environment. And these sort of things are interacting outdoor and indoor environment. And we also have our intervention and control. So this is a complex and dynamic system. So our cell body core temperature, as you know, about 37 degrees Celsius, and we got to maintain that temperature. And we also generate metabolic emission, like carbon dioxide, skin flake. If we are sick, bacteria and viruses coming out from us. And climate comfort and indoor air quality, they may not coincide. Climate comfort, we maintain our core temperature, as you see from the diagram. And if it is cold, our core body temperature always 37. If it is warm, the same. Okay? If you do exercise, this temperature increase, but we maintain that core temperature. So we may be thermally comfortable in the room, but they may not have acceptable indoor air quality. And there are several air contaminants, and indoor air contaminant could be, gas form or particle form, or they may be organic or inorganic. Some are visible, some are invisible. Some are harmless, some are harmful to us. And there are examples for gases and particles there, and there are also biological contaminants there. And if the particle size is very small, they could go deep into our bloodstream. Especially in this diagram, it shows the particle diameter is smaller than 100 nanometer. Nanometer is a 10 to the power minus 9, and that can go straight into your bloodstream, and that can be maybe harmful, depends on what you breathe in. And our noses and our system behave like the air conditioning system. We clean those larger particles in our nose. If you look at the airflow, it's got to change the direction. When it changes the direction, that will be coming in as a high velocity, so that will have a centrifugal effect, and that would the larger particle and heavier one, they will go to the sides of the channel, sides of the respiratory tract, and then some of those will be stay there, and smaller one they will go down, as you can see from this diagram. And we also keep the temperature, the outside air, warmer when we breathe in, so that lungs can take in what we call warm air as a same body temperature. And also we need the moisture level need to be saturated. If not, dry air that we lungs will not like it. And this reminded me of when my childhood, and I always had running nose when I was young. And if you look at typical air handling system, that we have it in our buildings, office building, and commercial high-rise building, or supermarket, these are very similar. I'm telling about the existing majority of the system, these are like that. We mix outdoor air and recirculation air, and together we have a supply air. So in commercial building, we don't do 100% outside air. However, in hospital, like operating theater, operating room, and intensive care units, they do have 100% outside air to make sure the rooms are clean, the airs are clean, air don't have contaminant. So the mechanism we use in air cleaning is a two mechanism there. One is dilution, and the other one is a filtration. You can see from this diagram, we have a lot of filters there. And again, depends on the quality of the filter, and they can filter small particle or larger particle. Like our face mask, they have some of them, they can filter very teeny tiny particles, and filtering efficiency, it's an important parameter for filters. And if you want to control the one that we do in hospital and clinics, it's like that, the one that's shown in diagram. We want to air move from cleanest room to dirty room. For example, air flow from operating theater, intensive care unit, and patient room, and maybe to isolation room, like tuberculosis, a room, and those sort of things. So this is an important concept in making sure that our environment, operating rooms are very clean. And these are the take-home messages out of my presentation. I'm mindful about the time, and you should be able to read yourself for that.
Great, thank you, Lou. And as I said before, we'll hold off questions. We're doing pretty well for time here. So now we're up to our final presentation, which is Lirian Daniel, who is a research fellow in the Healthy Cities Research Group at the University of Adelaide. She's interested in hazardous housing and its implications for population health and wellbeing. And her recent work has focused on Australia's hidden cold problem, energy hardship among tenant households and thermal standards for homes. And she's got the most interestingly titled presentation today.
Thanks, Beck. Thank you, everyone. So I'm just going to go through a bit about cold housing this afternoon. So in 2017, we were, chatting across many of our colleagues and with colleagues from much colder climate countries from the Northern Hemisphere. And we're looking at some of the limited literature in Australia. And it really struck us that actually Australian housing is probably fairly likely to be quite cold during winter, but we really didn't have any kind of, robust or rigorous database or data to test this idea. So in Australia, we're pretty well versed with the risk of heat, and we see ourselves largely as a very hot, sunny summer country. But it's really interesting that actually where most of the population live across the southern and eastern cities, Perth, Adelaide, Tasmania, Victoria, in Sydney, they're what we call heating dominated climates. So it takes more energy to keep us warm in winter than it does to keep us cool in summer. So that sort of goes against, probably largely how we see ourselves as, I guess, our country in terms of sort of lifestyle and our housing. So we often think about, the necessity to have deep eaves in summer around our home, but we don't so much think about insulation or double glazing or things to keep us warm in winter. So cold is really important to our health and well-being, as others have already touched on. International evidence has linked cold or exposure to indoor cold to some of Australia's leading causes of health burden and mortality. So, for example, Uncor touched on coronary heart disease in the first presentation, but as well things like respiratory disease, asthma, and even mental health. So we set off to look at this more, and this is probably the most recent evidence that we've got, and it's really exciting. We've just taken delivery of this amazing data set that captures the housing conditions of 15,000 rental households across Australia, so it's a nationally representative sample. And preliminary evidence is showing that the people with the poorest health across this population sample actually report the highest levels of cold housing. So we're really seeing, perhaps the people that should be in the best condition or the best environment, indoor environment, having the worst. So they're having to deal with not only existing health problems, but poor housing conditions as well. And this is something that we really picked up very strongly in more detailed work in 2017 as well. We monitored a range of houses across South Australia, across Adelaide, and we went to speak to people about their situations. So in general, the sample houses were really pretty cold. And when we looked at the coldest households, we really saw that there was sort of a build-up of multiple disadvantage. So things like social, economic, health, and sort of personal disadvantage among the coldest households. So for example, we met Sue, who had a disability support pension, lived in very old public housing, really poor condition, faced multiple health issues. And you can see from this graph that in 2017, during August, during our monitoring period, there was only one day during August that Sue's daily average temperature within her living room made it to 18 degrees, which, as others have mentioned, is the sort of at least the bare minimum temperature recommended by the World Health Organization, and you know, probably even warmer for people that are unwell, elderly, or quite young. So what was really important about this study is that we're seeing this sort of build up of disadvantage and sort of increased vulnerability among a certain sort of proportion of the population. So I guess, well, many of us, you know, Australian housing, as much as probably traditionally we thought it's pretty good, isn't fantastic in winter. So many of us might have cold housing, but most of us can also juggle things. We can maybe go for a brisk walk, we can put on another jumper, maybe switch on the heater and our electricity bill becomes a bit higher. But it's really these people that are facing multiple disadvantage, who are limited in the way that they can respond, who we think would probably be more likely to actually experience harm to their health and well-being from cold housing. So we suggest that that's actually the people that we really need to focus on targeting these kind of housing interventions to, for example, as Ankur described in the first presentation. So when we might be thinking about different kinds of assistance, because different people have different situations and different vulnerabilities, we actually went out and asked people what kind of assistance they would prefer. So, you know, often we might just go, okay, everyone can have the same assistance package, but we're sort of arguing that actually different people need different things because they face different barriers. So from a choice modelling experiment, we found, for example, that lower income households prefer unconditional assistance. So, for example, a bit of extra cash in winter to help with energy buildings. But there are negative preferences for things like cash or concessions among different groups, so people with children. Material improvements were most important to people with poorer health. And then really interestingly, people living alone showed the strongest preference for really any kind of assistance. And I think that just points to how difficult it is to have a living cost these days with a single income or, you know, single income support payment or pension. So I guess in further thinking about how we might then get to these more vulnerable people, you know, target interventions or provide assistance, other work that we've done looked at cold housing and found that it really sort of mapped existing patterns of social and economic disadvantage. So that might give us an in on how we might reach people in need of housing interventions. So we might think about it in the same scope as income support payments, a healthcare card or concessions and things like that. Because we're really seeing, and well, perhaps with COVID, we see this widening of social and economic inequality within Australia, and it's really the people who are doing worse or who are already doing poorly are going to be doing worse, and we might be able to use those existing sort of welfare measures as an in for housing interventions. So thank you.
Great, thank you, Lirian. That was fantastic. So now I'm going to ask all the presenters to put their cameras back on and open up for questions and comments from participants. You can either put something into the chat, or actually I think you can only put something into the chat. And so, hold on, enter questions in Q&A or chat. So I have just a question for Ankur about his cold housing work so far. Ankur, where do you see that work going? Like, what are the next steps in this project in terms of either expanding it out to other health outcomes that might be of interest or might help us get a bit more of a sense of the size of the contribution of housing to the burden of disease? Or is it adding more complexity to the models?
I think it's a very interesting question. I think it can go in multiple directions, one of which is obviously, so right now this is a very conservative estimate of how much public health burden is due to indoor cold, because we're not considering chronic kidney disease, we're not considering COPD, asthma, where there is sort of still strong evidence of the relationship between indoor cold. So that's something where this can go, is including more diseases in the model. But also, it could be, right now we've sort of had a magic wand, but that's not the case how it operates in reality. So I guess there are multiple interventions that can be targeted onto indoor cold. And that's where those comparisons now become quite useful as well, because those are which can be actually applied to the population. And the third thing is really, as the data evolves, I reckon potentially there would be a lot of scope to improving and bringing more confidence into the numbers that we are looking at right now from this analysis.
Great. So there's lots to be done. I have a question for Lirian. When you say there was a strong negative preference from people with children for concessions, could you explain a little more and any theories why?
Absolutely. I think we're really at the early stages with analysis of that choice modelling experiment, but we found that people were sort of respondents were quite strong in their preference for concessions, or they were quite negative about concessions. So, and on the other hand, preferred things like solar panel rebate or, insulation upgrade and double glazing. So I suspect, but this is just a guess at this stage, that perhaps it has something to do with how people see broader welfare mechanisms within Australia. So they might not perceive themselves as a house needing that kind of financial sort of welfare, but then it might be more acceptable to have a rebate on a solar panel. So perhaps there's something around the perception of accessing that particular type of assistance that is stronger for some people and not for others. So that's what we're working with at the moment, but it's definitely something that we're really keen to look at in more depth.
Great, fantastic. And I have a question specifically for Lucy here. Was there any political or media pushback in New Zealand on introducing the new rental rights about the quality of housing? And this is a major barrier in Victoria, where proposed changes have been weakened by homeowner reps claiming this is too expensive. So I guess what was the situation in New Zealand?
Yeah, so there was pushback from landlords who were concerned about the cost, and we had done a lot of work in our group beforehand looking at what the cost of these sorts of interventions might be, and that was helpful in terms of kind of getting a sense of whether those concerns were reasonable. Media pushback, not perhaps as much as you might expect if it had come out of the blue, but I would say that in the last 20 years, really, we have been creating that policy window that made it possible to bring these changes in, and that really did take time of kind of ensuring that the public knew what the health benefits were of warm, dry, safe homes, and that they so that the public was pushing for it as well, and that then made it possible for the government to make those changes without fear of voter backlash. And then also we've had a rise in the proportion of people renting, which means that there's greater awareness of the effect of poor quality rental housing on the population. So it has taken time.
Yeah.
Yeah.
It's good to hear it's achievable.
Yeah. Well, you need a sympathetic government as well.
Yeah, true. A question for Lou. Have you considered the passive house standard and the benefits it brings in terms of thermal performance and indoor air quality?
Okay, passive house is a very good example for saving energy. And some people talk about passive house in terms of energy, that save energy. However, and some people are saying that increase their embodied energy. So we need to be a bit careful about that. And another one is a passive house and indoor air quality. Indoor air quality is what's in it, what's inside, okay? How is the air move? As I mentioned in the presentation, there are two ways of cleaning. One way of cleaning is a dilution. whether we like it or not, we have an air leak come in. The more air leak come in, the better for, indoor air quality. But if you ventilate your home with passive, if you can open the window, that's good. Assuming that you don't have what we call your house is nearby the road, a lot of public people moving around. So assuming that outside air is clean, yeah, that's a good thing. Yeah. I'm not quite sure whether I'm answering the question you asked or not yet.
I think you've done well there. That was very interesting.
Yep.
Another question for Lirian. With the relationship between cold housing and self-assessed health, to what extent do you think this is a causal relationship and in what direction? Is it also possible that unhealthy people end up in worse homes?
Yes, now, I mean, Rebecca, you're probably better to answer this question because you're the epidemiologist, but I think it is likely, like the work that you've done on housing affordability, it's likely to be a bidirectional relationship. So I guess if we have poor health, it might impact our employment, our ability to earn a decent income and to access decent housing. So thereby being in poorer housing. But also, we do know that physical housing and other housing conditions impact on our health. So it probably goes both ways. And I think just generally with cold housing and housing indoor environments in general, it's such a complex area that it is quite difficult to really pull out these very precise relationships between, I guess, exposure and outcome.
Yeah, that's a good answer. It's almost like you're an epidemiologist now, Lirian. Well done. I have a question for Lucy. So your New Zealand story of impact and effectiveness at implementing regulation is impressive. I wonder if you have any advice for us Australians on how you did this. I could have anticipated this question.
Yeah, it's a really tricky one. I think it's the usual story of kind of working out what people care about, what their values are. So here we had some particular things that really made a difference to the population. So people care about the health of children, and when we can show that children's health is really strongly affected by poor cold housing, then that's something that people care about. Not something that I would want you to make happen, but there was a tragedy where a little girl who was living in a state house died, and the coroner commented that that the condition of the house was a likely factor in her death, and that brought a lot of attention to the issue in New Zealand, and I think really pushed forward that agenda of making sure that people wanted healthier homes. So it's really kind of my advice would be work out what people's values are, where housing and health intersect with that, and then you need a champion, someone who is really going to push that forward and pick up every instance that might help encourage people to see housing and health as something that matters.
I think the advice on the impact of children is interesting, actually. Yeah. I have a question for Angkor about incorporating some of the effects of heating into the model, so dehydration, etc.
Not at this stage. So I think what we've done is, as I said, this was a pilot project. So we pretty much focused on wherever we could find the most evidence and data from. But I think obviously, with further modifications that is possible, there shouldn't be any problem in including those into future.
Thank you. And this is a question for all panelists. So what can we do as policymakers to assist our most vulnerable groups in our communities to overcome cold housing without increasing their energy bills?
I can have a first crack and then others can add if you like. So I would suggest that mandating minimum housing conditions is something that's absolutely critical, or mandating minimal building standards. So at the moment in Australia, we have the National Construction Code, but that and energy efficiency provisions within that only applies to new homes and significant renovations. So, you know, we're seeing for existing homes, things like in Victoria, we're seeing minimum housing standards for rental properties coming in, but I think we need to see probably national leadership on that kind of thing, on minimum standards for existing homes. So that's my 2 cents.
Anyone else comment on that one?
Yeah, I just to chime in, I mean, very much in that space that that when you've got minimum standards, particularly things like insulation, where the person living in the home can keep it warmer with the same amount of energy use. I'm assuming that in Australia, as in New Zealand, those who are particularly economically vulnerable are more likely to be living in rental housing. So it's then the cost of those interventions is borne by the landlord rather than by the people living there. So those, and energy efficient heaters and so on, those are the sorts of things that enable the person living in the home to keep themselves warm without using more or as much more energy as they might.
And just to follow up on that, actually, Lucy, because I realise that you have to go at 5. There is another question for you about where did the 29 points in the Warrant of Fitness list come from? Right. And what was the process for developing these? Yeah. You've got...
I've got 7 minutes, so it's plenty of time. No, so we started out with something that was the Healthy Housing Index, which was developed for research purposes, and that was kind of like a 60-page list of anything that that our research had shown might make a difference to the health of people living in homes, and that was too long to use for some sort of standard for a rental property. It took about half a day or longer to do, and we needed something that was sort of 1 to 2 hours. So we worked with the New Zealand Green Building Council to sort of condense that into those 29 points. And then we took that out and ran a field trial, tested it to make sure that it was deliverable, that it worked, and also out of interest to see what sort of results would come in, although it wasn't really a scientific random sample. So that was kind of how those 29 points were developed. We initially had 31, and after the trial, it was a few changed, and we were then down to 29. So that's the short version.
Lots of background work there. Yeah. Now, a question here. Maybe this is best for you, Lou. But what about the impact of chemicals used in construction and furnishing materials on occupants' well-being? And are there any major studies advocating platforms targeting this issue in Australia and New Zealand?
Yeah, before I answer that question, may I answer about NCC, current NCC? Consider energy efficiency, insulation, and thermal comforting. We haven't got a detail about air quality. Only things in there is a non-volatile, organic compound. Volatile organic compound. Okay, so that's a current NCC. Could you repeat the second question, Rebecca? Sorry.
Yeah, no, that's okay. It was about the, it's scrolled down my thing now, but about the chemicals in furnishing and other indoor environments, their impact, and then if there's any research or work being done around this in Australia and New Zealand.
There are a lot of study around what we call household and, like perfumes and household usage, those. And another thing is a building usage, and these are the one, for example, paint. There are some study there, and that's they generate volatile organic compound, like the smell and newly painted houses, and these are established there. However, we don't have a consumer product like perfumes and house cleaning and those sort of things. And we have in our department Professor Anne Steinman looking at those issues. Yes.
Thank you. Now, we've got a few minutes left. I'm going to take 2 more questions. I'm going to ask one to Lucy first, because I do know that she has to go. But Lucy, wondering what you think of the role of each industry involved in housing in championing this and taking responsibility for improving the quality of housing beyond following current policy. So I guess this is a question about championing housing change and the role of industries in that, or different sectors.
Yeah, I mean, that's an interesting one, because, you know, you would expect that it would be in the interests of industry to champion better quality housing, because then they get to upsell their products. I mean, and that's sort of in the private sector anyway. And then you have other parts of the industry, the sort of the property management and so on. Generally, that there is huge benefit for all of them, whether it's in the kind of in the long-term, the longevity of the property that they're building, or in the products that they're selling. So I think, you know, industry certainly has a role there. In New Zealand, we talk about the building code as being the worst house you're legally allowed to build. I assume the same is true in Australia. I mean, by default, that is how it is. So it's kind of encouraging consumers to do better, and providing them with the information to make those choices where they are able to make choices. I generally avoid the choice language in a whole lot of other areas, but I think in this space it's reasonable to do that. Though when I was talking about a champion, I mean, I was sort of thinking of an individual or two or five who really kind of pushing this as something that Australia needs to change. So whether that comes from the industry or from academia or from the social sector, the NGO sector, it doesn't really matter, just so long as someone does it.
Yeah, or indeed from all of them.
All of the above, exactly, yeah. Working together, great. Yeah.
Now here's a controversial question for you, Encore. So is simulation modelling the best way to establish the relationship between housing, cold housing and health?
Interesting question. I think I'll say it's like horses for courses approach, or, you know, depending on your research question. For the relationship between housing, environment and health, I think you've got different designs. This is really taking what you've already obtained from those studies and then looking at what impact it may have on population health and arguing a case for all the different interventions. Now you can really compare interventions, which you cannot do with other epidemiological designs that you usually have. So I think it's just thinking about how to use the existing information. If you don't have those causal estimates, then you really need to do that first to be able to then simulate. So I reckon for some questions, we find that, yes, that evidence is really good and we can use that. But for many, the quality of evidence is not there that we can just use that to simulate. I hope that answers your question.
I'm sure it does. And then what we might do now is it's 5 p.m. I realise that some of our panellists have to go. And so thank you so much, everyone, for your time and your interesting talks and presentations. Some panellists are able to stay for an additional 10 minutes or so and answer outstanding questions, but I understand that Lucy has to go in particular. I'm not sure about
It's a pleasure. Thank you very much.
Thank you.
So
thank you for your time.
Honoured to be here. Thank you.
Now, there is a question here, Encore, again for you. Well, there's a few questions that are getting at this issue of whether you've looked at heat, but another one about about wood fire and smoke and indoor quality, you know, from that point of view. So maybe that's a little bit for Lou as well, but just it might be worth commenting a little bit on this issue of the health impacts of heat and hot houses. Again, yeah.
Thank you. I think when we proposed the project, the idea was to do both cold and heat. But I guess over the course of time, we've realized that, you know, you can't do everything together at once. So I guess that's why we, like, looking at the evidence, we preferred doing cold first. And I think obviously it is a plan, it should be a plan to look at heat as well. I think the question around the wood fire and using that to actually heat the house is quite an interesting one. And I'd really like to hear the perspectives from Lou here as well on that. Because I think there's a kind of a counter action in terms of health on that front. So I guess what we really need is sort of really good epidemiological studies to actually tease out that relationship between the two factors, whether they are actually, you know, I mean, in terms of multiple health outcomes, what is happening there. So I guess that's not a very straightforward answer, but I guess the complexity of that relationship is as such that we need probably a better evidence on that.
Thank you. And I might just get Lou to comment on the wood
Yeah,
fire.
in terms of heat, if you have a very hot day, you could easily get heat stroke and those sort of things. So heat is not good for health neither, right? And what about cooking, indoor cooking? And we also cook, what we call gas burner inside. And some of them, if they are not, properly designed and properly, do that, they also generate carbon monoxide there. And I always make sure that we switch on the rear, ventilation fan, and then open the window if we can, and those sort of things, we should be doing that. And these things are not noticeable, but they're all there. Carbon monoxide, especially, we don't have the, gas leak. Yes, we know gas leak, we have the smell, intentionally put it there. And wood fire, again, depends on how you have it, wood fire. Wood fire, some of them are, isolated wood fire, and that the smoke cannot come back inside the house. Make sure the smoke's going outside, and all sorts of things are there. Yeah, we need to look at the individual, system. Especially, we need to be mindful of these sort of things exist there. That's all important. Whatever we do, sometimes we don't see, we don't smell, we think they are safe. That's not quite right. Yes.
All right, and so to finish up, I have a question to all of the panelists, and I might this will be the last question, and I might get each of you to respond to it. But are there any established works of research on the effect of COVID in terms of housing and the place of stay, so where people are staying during COVID? I might start with you, Lurian.
Thanks, Beck. So I'm not sure. There's been a few studies, like I believe one has come from your group around maybe population density or housing density and perhaps transmission. But one of the really exciting things that's coming out soon is, I mentioned during the presentation, this collection of data on housing conditions of rental households. So this project is led by Professor Emma Baker from University of Adelaide. And we were lucky enough to get some additional funding just before the survey went to field. So just as COVID hit. And so we have a series of questions within that survey about living conditions during COVID. And in the next sort of, I guess, month or few months, we're really hoping to speed up that preliminary analysis and get some of those stories and that information out there for policymakers and the general public as well.
Thank you. We're looking forward to getting that information out. It's been a really interesting project.
Yeah.
Angkor, do you have any comments on that?
Thanks. I think the evidence is like it's happened so quickly, and there's like the process of research sometimes takes quite long. So I guess it's in a process of evolving, and I think probably there are not lots of evidence out there yet, but I think the process has started of collecting. What I'd be really interested in something like short-term and long-term impact of what is happening right now, because we're all living through an experiment per se in terms of our housing right now. It would be tremendous to see how that impacts, both immediately, but also in the long term as well.
Do you have any comments on COVID-related considerations or research that you're aware of at the moment?
Well, regardless of whether we like it or not, if vaccine not there, we got to live with this. And we need to go back to our offices, and we need to have a business back again. So I'm seeing that, we will have a lot of retrofit will be happening, and that's the future. And our NCC will be changing, and all sorts of things. Indoor air quality will be the, next step we must look at. And we have advertised a PhD student to look at how do we retrofit existing building to make sure better indoor air quality. And retrofitting is a big issue. And new design, yes, some of those new design. Shall we be designing our houses like hospital? Maybe that's a requirement. maybe restaurant, should we be designing restaurant air conditioning system like hospital? So those sort of things are important. And what we can do at this moment at home is, if you have one family member sick, we will isolate that, but make sure that airflow coming out is, clean room to the, sort of isolation room. And again, we don't have choice. We have a family, all right? So we need to be very careful. And again, there is what we call our groups looking at the call for research grants, and then, research project happening there, what we call supported by Western Health.